people are still joining in. I welcome you all to the 39th webinar of the Conceptual Basis of Urology course. My name is Hamad Athar. I'm Professor of Urology at the Khan University. And tonight, we are discussing a very interesting pathology, which is priapism, something that we don't see very frequently, but when we do see, it is something that we should be absolutely sure how to take care because it has significant long-term consequences. With me, there is Dr. Nasser Suleiman, an old-time colleague who is one of the pioneering andrologists in Karachi. I've learned quite a few tricks from him, both in the field of urology and andrology. So welcome and thank you very much, Dr. Nasser Suleiman. Our three speakers tonight are Dr. Iman Yunus, who is going to talk about priapism diagnosis and acute management, which is an extremely important and conceptual area that all our trainees and young consultants should be very much abreast of. This will be followed by Dr. Wajahat Aziz, who is an andrologist at the Khan University. And he's going to talk about some of the recent advances and changes in the management of priapism in the era of penile prosthesis. The last talk of the evening is by Professor Mohammed Arafa, and we are fortunate to have him this evening. And he is going to talk about early versus delayed penile prosthesis at the end. So priapism is a condition which is a true urological emergency. We know that it is associated with consequences, which includes erectile dysfunction, which can be really devastating. We know that if conservative treatment fails, there are various distal shunting procedures, which includes Algorab shunt as well, which is very effective. However, there are issues at times with the use of penile prosthesis in patients who have had a Algorab shunt. Is there any current role of proximal shunting, and what are the consequences? This probably will be taken up by Dr. Yunus. When we are managing priapism, obviously time is the essence. And if we don't do things on time, there are corporal fibrosis, which can have devastating complications. So how long a medical management should continue? Early penile prosthesis is something that is being talked about, and Professor Arfa is going to take up this extremely important subject. Is there any role of MRI and penile prosthesis and corporal biopsy to really document the extent of ischemic injury? So with this background, I'll be inviting the first speaker soon. We all know that Conceptual Basis of Urology course is a once-a-month exercise that we've been doing for the last 3 years. There are over 38 courses in the past, and they're all available at the PAUS Karachi Urology website at pauskarachi.org. They're freely available to anyone who would like to go and see these courses. This is a joint collaboration between Aga Khan University and Pakistan Association of Urological Surgeons, Karachi chapter. So with this little background, I would like to invite our first speaker. I'll unshare my slides so Dr. Iman Yunus can share his slides with us. We in Pakistan all know Dr. Yunus. He visited us in the last association conference in Karachi. Dr. Yunus is a very well-trained urologist. He is board certified both from UK and Europe. He has over 15 years of experience, although he practices general urology as well, but his main area and major area of interest is andrology. So today, Dr. Iman Yunus is going to talk about priapism, acute management, and diagnosis. Dr. Yunus, the stage is yours.
Thank you very much, Prof. Hamad, for inviting me. And yes, it was an absolute pleasure to visit Karachi last year. And I'm hoping to repeat the experience again in Islamabad this year, inshallah. Thank you for inviting me, and very nice to see the other speakers as well, and hopefully to meet them in person. So my talk today is about priapism, maybe the basics, the introduction, the acute management, and before that, the diagnosis. Yeah, so priapism. I chose this introductory slide basically to refer to where this word coming from, priapism. And this is basically the photo of the monument and from the Italian heritage and culture. It's about Priapus, who was the god or the rustic god of the bounty of the vegetable garden. So he was honored as the protector of sheep, goats, bees, and vine. He was depicted as a dwarfish man with a huge penis, which symbolizes fertility. So that's where the word priapism came from. So in my short talk, I'll be talking about definition, types of priapism, how to diagnose it, and how to manage it. So as an introduction, priapism is defined as the complete or partial penile tumescence that persists for more than 4 hours in the absence of sexual stimulation or after ejaculation. I think in the very old days, we've been taught that priapism is undesired painful erection, but it's not necessary to be painful. It is, as you said earlier, Prof. Hamad, it's quite rare with an incidence of 1.5 per 100,000, and it can occur in any age group, but any age group has a specific cause. And there is a bimodal peak incidence between 5 and 10 years, as well as in adulthood, 20 to 50 years. So before we talk about priapism, we need to differentiate about the types of priapism, because that will help us quite a lot in managing priapism. So priapism is divided into either ischemic or low flow priapism, or non-ischemic type or high flow type. So in ischemic type, usually it's idiopathic. However, there are some conditions that is associated with it, the most common and famous of which is sickle cell disease, although it can also occur in thalassaemic patients, leukemic patients, and so on. Also, infection causes such as rabies, malaria, metabolic syndromes and disorders, neurogenic disorders, malignancies, and as well, more favored and famous as well is the presence of medications, especially illicit drugs, antipsychotics, and PDE5 inhibitors, or any medications for erectile dysfunction. In the high flow type is less in proportion. Usually it happens after pelvic traumas, with a perineal blunt traumas. It can also occur in metastatic or malignant conditions affecting the penis. It can happen in acute spinal injury, and it can also happen from repeated intracavernosal injections. So when it comes to the low flow type, it is one of the types, is the most common type, accounting for more than 95% of the presentations. Usually patients present with marked rigidity of the corpora cavernosa. They typically complain of penile pain, and examination usually reveals rigidity of the erection and the corpora with relative flaccidity of the glands. So it can be like a compartment syndrome, and that's where the urgency in managing this type is, because with compartment syndrome, that leads to venous stasis within the corpora because of the obstruction, and it can lead to intracavernosal acidosis, anoxia, hypercarpia, and glucopenia, and all that can lead to fibrosis and the disastrous long-term consequences of this presentation. On the other hand, high flow priapism or non-ischemic type, usually it is a persistent erection caused by unregulated inflow of the cavernosal arteries. So there's quite a lot of flow, oxygenation is always there, though this is of a low risk, and that's why it have more time to deal with it. So fistulation occurs between the cavernosal arteries and the sinusoidal tissue that leads to incomplete tumescence. So it's less rigid than the ischemic type, and there will be less fibrosis and less deoxygenation and necrosis of the corpora. In fact, there will be no necrosis at all. There is a third type. In fact, it's kind of a mixture. It can be a mixture of both types, but it can be considered that the third type is a stuttering priapism. And this is a condition whereby patients experience frequent recurrent episodes of priapism. Usually it can last less than 3 hours. The prototype of which in this condition is patients with sickle cell disease. So it's part of sickle cell crisis. And usually it's self-limiting in this group of patients, but sometimes if it's lasting for a longer period, that will warrant more acute management, mostly similar to the priapism ischemic type. And we'll talk about it at a later stage. So when it comes to management, like any clinical condition, you always need to start by ABC of medicine, taking history, physical examination, investigate, and then manage according to what you found. So I took this slide from the BAS recommendation. Acute priapism should be classified. So the most important thing is to classify the type of priapism, and that will shed some light on what sort of management you're gonna follow. So when it comes to history, the most important thing is to establish the onset of the erection. So when did that happen? And in that, to help you in managing the case, you need to classify it whether it happened before, within 48 hours, or between 48 72 hours, or longer than 48 or longer than 72 hours. You need to look into your history about or for the reason for the priapism, whether there is any hematological disorders, medications, what are the symptoms, anything to suggest the presence of malignancy, any trauma, and so on. When you examine it, a general examination, abdominal examination, rectal, penile, and to some extent, you need to perform neurological examination, as that will shed more light into your approach and management. So when to investigate. So the most important step here is to alleviate the patient pain. And you cannot alleviate it without releasing the tension, especially if it's an ischemic type. So the most important step in investigating priapism is to take a corporal blood gas. But before that, you can take some general blood tests, including full blood count. In some patients, you may need to think about blood film, especially if you're doubting sickle cell disease or any other hematological disorders, as well as autoimmune screen for some autoantibodies. When it comes to corporal blood gas analysis, you need to check the oxygenation, the acidity of the aspirate, whether there's any glucose. Basically, you need to differentiate whether this is ischemic type or arterial type or high flow type. And it's quite obvious the difference between the two. So in ischemic type, usually the blood is acidotic, the color is darker. There will be more indices to help you to classify the priapism. How to do it? I'm not sure if any here got experience with that. Most of us have, but although not very much. So basically, you apply a ring block or dorsal penile block, and then you insert a 19-gauge needle or a butterfly needle into the sides, 9 o'clock and 3 o'clock of the base of the penis to avoid any neurovascular bundle damage. You aspirate, and from the aspirate, you send it for blood gas analysis, but you keep aspirating because aspiration is one of the steps in managing priapism, especially if it's of ischemic type. Obviously, abandon the procedure if you're not going anywhere. If it's not possible to aspirate, that indicates that there's quite a large of clot in there. And at that point, you go to the second step in ischemic type, but we'll talk about that later. And I'm referring to the installation of the sympathomimetic agents, phenylephrine. Imaging, maybe you don't have a lot of time to image, especially in ischemic type, but if you do, if you're in doubt, you can request a penile Doppler, which is quite easy. Basically, you want to check the flow and the pressure inside the penis, whether there is a valid flow inside or not. Abdominal CT or abdominal MRI scan, this is a later step, especially if you're thinking about malignant disorders affecting the pelvis. Penile MRI in doubtful conditions, but it's not available all the time. So this is an overview slide on how to manage priapism. As you can see from the chart, that you always need to diagnose firstly by establishing the type. If it is ischemic, you go down the route of the ischemic, and we'll talk about it a bit more details. And if it's non-ischemic, there is a different approach. So when it comes to management type, as I mentioned earlier, it's a type of compartment syndrome which warrants an urgent or emergent intervention. Firstly, you need to alleviate the pain. You need to perform the penile aspiration, and that will give a bit of a relief, especially if you're releasing the compartment syndrome and the pressure inside before the disastrous consequences of fibrosis and so on. I brought this slide as well from Baus' recommendation. I'll pass the slides later to Prof. Hamad. This is basically what to do and how to dilute the sympathomimetic. You use this step if you fail to alleviate the symptoms by aspiration only. And in that case, you need to apply the sympathomimetic in order to open the sinusoidal valves so it can release the tension inside the penis and allow more arterial blood to go in order to replenish the area. The general idea here is to dilute the phenylephrine because usually it comes in a 10 milligram ampules, and all what you need from the 10 milligrams is only 200 mics. And you repeat this step once every 10 minutes till you get detumescence, and that will relieve the patient. And you do that only if the presentation is within 48 hours. But sometimes if it's longer than 48 hours, or you fail to alleviate the tumescence or detumesce the penis, even if it's below 48 hours, you may need to think about shunting. The most common, the simpler, is the distal shunting. And there are, some types of operations or procedures that you can do. The most classic, the most commonly used is the T-shunt. And in simple terms, you insert the 10 blade into the glands and into the corpora, the distal end of the corpora, and then you flip it or you turn it by 90 degrees. And the idea here is to create a fistula. So you can connect the corporal blood into the arterial glandular blood. And that will form a sort of shunting. It will divert the pressure into the arterial system via the urethra, the cavernosa, sorry, not the cavernosa, the spongiosa, and that will give you a bit of a relief. In patients who present later than 48 hours, later than 72 hours, and that will be covered at a later stage, the trend is to go straight for penile prosthesis. Unlike what is drawn here in the picture, usually you go for a malleable penile prosthesis, but I'm not going to talk much about it because I'm sure there will be a colleague speaker who's going to talk about it. So going back to the ischemic priapism, you need to follow this chart, aspirate, establish diagnosis. According to the onset of the presentation, you either go for continuous aspiration till you get a bright red blood, or you instill the phenylephrine. And in cases of longer presentations, you need to think about shunting. Failing all that, you may need to think about early penile prosthesis insertion. So sickle cell disease, that's a prototype of one of the conditions that is presented in sickle cellers or sickle cell patients. You consider it mostly as an ischemic type. I don't think we need to talk much about sickle cell disease. That's a different and beyond the scope of this lecture. But you involve or you apply the same principles of managing ischemic priapism, but you can add hydration because that's the most common reason for sickle cell crisis. Covering the second type, which is the non-ischemic or high flow type, usually it's a presentation after a pelvic trauma where there is fistulation. The risk of smooth muscle affection or necrosis or even fibrosis is quite low because the blood is always oxygenated. Usually it's conservatively managed, but you need to refer it to specialized center where they're going to check if there is any fistulation, where is the fistulation, and accordingly they either embolize it or they may need to think about surgical management, including ligation of the fistulation itself. I'm just going to jump the slides for the sake of the time. That's again the flow chart of how to manage ischemic versus non-ischemic. Prof. Hamad earlier talked about proximal shunting. I think this is a surgical type which is fading away because usually I think it has a higher morbidity as well as more complications, and it's quite more difficult. And with the new era of urological management, people are moving away from high invasive procedures into more conservative, less invasive procedures. And that's what we've been taught in the newer modern era of urology in the UK. We didn't learn a lot about ligation, and we kind of relying only on distal shunting. So to conclude, or actually to highlight the most important message behind this presentation, ischemic priapism is a urological malignancy, or sorry, urological emergency that mandates urgent detumescence. That's your most important goal, to alleviate the pain and alleviate the detumescence. It renders the design and execution of high quality randomized study challenge. It's quite challenging because there is not a lot of data in it. There is some evidence surrounding the management of priapism, and it's generally low level, so it's mostly level 4. There's current guidelines based largely on small retrospective series and expert consensus, and I rely heavily in the BOUNCE recommendation, and I'll pass a paper to Prof. Hamad, hopefully to distribute it amongst yourselves. Thank you very much.
Thank you very much, Dr. Iman Yunus. Wonderful, comprehensively covered in a very short time. And before we move on to the next presenter, there's just one question about how to prevent recurrence. Is there a recurrence in following an ischemic or low flow priapism?
Yes, it can recur, especially in sickle cell disease sufferers. Patients who are actually taking illicit drugs, so it can always recur, and if it happens once, there's more likelihood that it's going to happen again and again. Dehydration, people who live in quite hot climate, patients with leukemia, patients with malignancy in general, it can recur. How to prevent it? It depends on the cause. Obviously, prevent the cause, avoid the cause. Patients with sickle cell disease, they need to be well hydrated all the time, not only to prevent priapism, but they have other crises like avascular necrosis of the femoral head and so on. So depending on the cause, you can prevent. Paradoxically, although PDE5 inhibitors is one of the reasons why people get priapism, paradoxically, you can give PDE5 inhibitors in patients who've had even ischemic type at a later stage, so you can maintain good flow of the penis. And I found it quite confusing in the beginning, but it makes sense if you give the patient PDE5 inhibitor regularly at a later stage, under your supervision as a clinician, you encourage more flow into the penis and hence less ischemia.
Right, thank you. There is recommendations about use of PDE5 inhibitors within 2 to 3 weeks following an episode of ischemic priapism. Does that incur increased risk of recurrence of priapism?
That's what I mentioned earlier, paradoxically, and initially illogically, you give PDE5 inhibitors to prevent, but Once you stabilize the acute phase, you kind of maintain regular flow into the penis, and that will make it quite a healthy environment for continuous oxygenated blood to go in. But only if you're stabilizing the acute phase and you go into stabilizing or maintenance type of management as part of rehabilitation the penis after the acute event.
Thank you, Dr. Yunus. We move on to the next presenter, Dr. Wajahat Aziz, currently assistant professor at Aga Khan University, and he's our andrologist. So Wajahat, the floor is yours. Please proceed.
So thank you, Iman. This sets nicely. So I would talk about what changes recently have happened in the management of priapism. Iman have hinted towards them. I would just summarize those points. So just to summarize the traditional approach, you start off with your history and examination, which is focused mainly upon what is the duration of priapism, and secondly, possible underlying factor which may have triggered it. And as people have asked, neurological causes is one of them. It is known to happen in patients with spinal cord injuries or even with disc herniation. Okay. Then second step is aspiration irrigation, and usually you combine it with a vasoconstrictor. And failing that, you go for a distal or a proximal shunt. So firstly, talking about diagnostic investigations, the diagnosis of ischemic versus non-ischemic priapism is based mainly upon blood gases. The penile Doppler itself does not sensitively predict ischemic versus non-ischemic priapism, and it can miss a low flow type of non-ischemic priapism, and it can confuse, because in penile Doppler, if you find a low flow, then it could be anywhere from a normal anatomy to ischemic priapism versus a fistula. The real reason why MRI is somewhat catching up is in those patients in which there is a concern whether necrosis has set in place or not. So penile Doppler would basically pick up the flow. The MRI would add, MRI with contrast would add what are the areas of necrosis. Now this becomes important if you are considering a patient for an early implant, because you need to have some evidence of necrosis which has set up. Ultimately, you may find out on histopathology, but a non-invasive way of doing that would be an MRI scan. And it would also be appropriate to get it done from a medical legal perspective. Secondly, I recently had few patients who had a distal shunting or some procedure done elsewhere. That is also again a situation where an MRI would be helpful in finding out what exactly may have happened elsewhere. The second step in management is usually aspiration irrigation, and you can combine it with one of the vasoconstrictor. The usual method is to insert a butterfly needle, usually somewhere between 9 o'clock and 12 o'clock. It may not be absolutely necessary, especially there is increasing experience with intracavernosal injections, especially for those patients who receive it during a diagnostic penile Doppler ultrasound. In these patients, what happens is so-called iatrogenic priapism. Those patients who are either prescribed for a diagnostic or therapeutic purpose. These iatrogenic priapism in these patients, the idea is very simple. Up to 2.5 or 2 to 3 patient, every 2 to 3 patient, if you perform a diagnostic ultrasound, they would have an erection lasting more than 6 to 8 hours. And those are usually younger patients. And the traditional approach would be to send them to ER, perform an aspiration, irrigation, and injection. But what makes reasonable sense is just to give them an antidote. You have given them a vasodilator. So just give them an antidote, usually in the form of phenylephrine. There are multiple practical considerations with use of phenylephrine. The usual ampule which is available is this one, 10 milligram per ml. If you dilute it in a 10 cc syringe, that would become 1 milligram per ml. And I have found it practically very useful to aspirate 1 cc into an insulin syringe. That 1 cc, that is the maximum dose which can be given, 1 milligram per ml. And usually it is given in an adequate of 300 to 500 micrograms. So you can give 300 to 500 units every 10 to 15 minutes. Also of note that half-life of this phenylephrine is usually 2.5 to 3 hours. So you can repeat this procedure after 2, maybe 3 hours. So most of these patients who have a known agent causing priapism, you can simply use this antidote and you do not even need this therapeutic aspiration irrigation, which is a very painful and scary procedure for the patient. Regarding the shunt procedure, this distal shunting, as Eamon previously have mentioned, it is a very damaging procedure and sometimes do not work. For patients who report later than maybe 12 to 24 hours, in these patients, this simple irrigation aspiration usually do not work. So they would require this procedure. The people have modified this shunt procedure so that you, through the same distal incision, you can pass a dilator and sort of create a tunnel so that all the blood flow from the proximal to distal can come out through the same incision. This is so-called snake maneuver, which is to be considered rather than a proximal shunt. Essentially, what it creates is a proximal to distal flow which covers whole of the penis. And people have further modified this technique so that if you pass the dilator towards the lateral aspect and a bit posteriorly, then there is a chance that you may avoid injury the corporal vessel, the artery itself. I would argue, and this is increasingly with literature, that proximal shunt, which were previously described, technique and all, it is an outdated procedure. And our next speaker would basically talk about this, why they are outdated, because they make the life of the implant surgeon so much miserable. So that's from me, a few updates regarding what have done in the last 10 to 15 years.
Thank you very much, Vajat. I think you have set the stage well for Professor Mohammed Arafah, who is our next speaker. And it's my pleasure to introduce Professor Arafah, who is participating in our course for the first time. He is a prolific researcher with over 4,500 citations, an H index of 34 and I-10 of 65. He is professor of Andrology in the Cairo University and also in Hamad Medical Corporation. So it's a pleasure to have you this evening, Professor Arafah, and to talk about the penile prosthesis, which is becoming the most important tool in the long-term management of patients with priapism. Thank you very much.
Thank you, Dr. Hamad, for the inviting me, and thank you for this very interesting educational activity. It's my pleasure to be here today among colleagues and friends to present the last part of the management of priapism. I believe my colleagues, Dr. Yunus and Dr. Aziz, have made my life very easy and have said most of the things that I am going to discuss here. So without further delay, I have no conflict of interest to disclose. As we said, the priapism is characterized by prolonged and painful erection that's unrelated to sexual stimulation. As Dr. Ayman said, it's derived from a mythology, although it's not known to be Greek or Italian, but mostly my references come from the Greek mythology of Priapus, the god of fertility. Anyhow, The types, as discussed before, we have the ischemic low flow priapism, the non-ischemic high flow priapism, and the stuttering priapism. Today we'll go for the ischemic priapism. So what is the refractive priapism that I added to my title in the title of the presentation? Refractive priapism is the priapism that fails to fade or it's not treated after all the maneuvers that Dr. Ayman and Dr. Aziz have said before me. As said before, also the incidence is low, about 1.5, 2.5 every 100,000 persons per year. However, this increases so much with sickle cell disease, reaching up to 35 to 45% in adults. With, of course, the two high incidences in between 5 to 10 years, mainly related to sickle cell disease and other hematological diseases, and the other peak between 20 to 50 years, usually related to iatrogenic or medications. The etiology is, Dr. Ayman has said it before, but the most important here for ischemic priapism are the hematological diseases like sickle cell disease and others, followed by the medications, mainly the intracorporeal injections and other medications that may pass unnoticed, like alpha antagonists, anxiolytics, some of the antidepressants. The most unfortunate will be those with malignancies, because this will be the type of priapism that will not go with any of the other maneuvers, because here there is actual infiltration of the venous outflow or blockage of the venous outflow with malignant cells. And again, the less unfortunate are those with toxins and infections like the scorpion sting or the spider bites, less commonly metabolic disorders and neurological disorders. Regarding the pathophysiology of ischemic priapism, I will say it very fast because this is important for what is happening later on with the penile prothesis. The impaired venous outflow lead to persistent engorgement of the corpora cavernosa. Then there will be low oxygen tension in the penis, which is ischemia, leading to the release of inflammatory mediators, leading to oxidative stress and the activation of apoptotic pathways. All this would lead to fibrosis and structural alteration of erectile tissue, ending with fibrotic plaques and erectile dysfunction. When we come to the histological timeline for the ischemic changes that happens, within the first 12 hours, we'll find interstitial edema progressing to destruction of sinusoidal endothelium. At 24 hours, there will be exposure of the basement membrane and thrombocytes will start to adhere. After 48 hours, thrombi will appear in the sinusoidal places, smooth muscle necrosis, initiating, and the fibroblast-like cells will be transformed, leading to initiating the fibrosis that is the ultimate outcome for refractory priapism. For the management, I'll also pass it very quickly, but I want all of the people, that our physicians and younger physicians, to know that although priapism comes to you in the emergency, he is still a patient. We have to take history and physical examination, as Dr. Ayman and Dr. Aziz has said before. We'll find for the ischemic priapism, it's painful with duration hours to days. And of course, we'll take the history and find some of the causes like sickle cell disease or injections, cancers, so on. On the contrary, with the high flow priapism, it's less painful. The duration is always delayed because the penis is not painful and it's compressible. And there will be a history of trauma or something that's causing the high flow priapism. Coming to the physical examination, we'll find the hard erection. Mainly, it's only in the corpora cavernosa, and you will find the non-rigid glands and corpus spongiosum. For the non-ischemic or the high flow priapism, it's less rigid, compressible erection, and we'll see the location of the trauma may be seen. Coming to the investigations, it has been well said by my two colleagues, but the main one is we go for the CBC again, and urea and electrolytes to detect any possible cause, coagulation profile again, and the cavernous blood gases to differentiate between low flow and high flow priapism. Doppler is needed, and MRI is rarely used. We rely on the Doppler to differentiate between the two causes. The management passes from the intracavernous injection of sympathogenic agents corporeal aspiration with or without irrigation, surgical shunts, and lastly, the penile prosthesis implantation. As you have noticed, Dr. Ayman and Dr. Hamad have always said early penile prosthesis implantation because we are always used to early penile prosthesis implantation. However, when you go to the literature, you will find that there is lack of consensus on the optimal timing to implant a penile prosthesis in such patients. Those who favor the early implantation say that we'll avoid the formation of fibrotic tissue, which will make our life miserable during implanting a penile prosthesis. While those who opt for delayed implantation say that during the active phase, there is extensive edema, the tissue is friable, and there is higher incidence of infection, especially after maneuvers like aspiration and irrigation and the shunt operations, because there is high incidence of infection and introducing bacteria to the field. So with this lack of consensus, we opted to do one systematic review and meta-analysis for for all the studies discussing the penile prosthesis implantation in such patients with refractory priapism. We aimed here to evaluate and compare the clinical outcomes between early and delayed penile prosthesis implantation in order to reach a consensus, or at least a defense for our idea of early implantation that we all opt to do nowadays. We chose studies focusing on refractory priapism that led to ED or that will lead to ED and its management with penile prosthesis implantation. We searched all databases, the 6 databases from inception till May 6, 2023. We did a quality assessment and we checked the odds ratio of complications. This is the PRISMA chart of our study. We started with 687 studies from the databases and 23 from registries. After screening and exclusion, we ended up with only 9 studies. 4 of them are cohort and 5 are case series. So you can appreciate how little is this once properly studied. When we come to our studies, we'll also see different things. First of all, the studies came mainly from UK with 4 studies, 3 from Egypt, 1 from Italy, Iran, and Qatar, and 1 from US. You will find that the definition of early and late is even different between each study. Some studies say that less than 10 days, some studies said less than 20 days is early, and others opt for other time ranges. For delayed, some consider delayed if up to 4 months delayed, that can be called delayed. As we said, we identified 9 studies, a total of 278 patients that underwent 318 penile prosthesis procedures because some of them needed revision of the penile prosthesis implantation. To check the quality of our the papers, to see the quality of our recommendation of our findings, we found regarding the case series, there was a low to moderate risk of bias. Collectively, it was a moderate risk, which was also similar to the cohort studies ranging from low to serious risk of bias, but again, collectively, it came out as moderate risk of bias. All the studies have, that when we see the total complication rate in all the studies, it is much higher in the delayed group than the early group, with the odds ratio of 4.16%. So we find that the total complications are higher when we delay the intervention with penile prosthesis in such cases. Coming to the complications one by one, the fibrosis, of course, it's expected to be much higher and much difficult with delayed implantation than early. The erosion of the penile prosthesis following implantation, although it was more presented by those having delayed implantation. However, there was no statistically significant difference when we compared between early and late patients in the meta-analysis. So the erosion is not our issue here. Again, with infection, there was no statistically significant difference between early and late, and this abolishes the idea that early implantation may cause more infection. And we found that there is no statistically significant difference between these two, the early and late, on the pooled data. Urethral injury. Because the fibrosis is higher in the delayed implantation, we'll expect more maneuvers during penile prosthesis implantation in these cases. So the urethral injury will be increased, and this was our finding, statistically higher in delayed than in early group, with the odds ratio of 1.83. The odds ratio is less because the urethral injury shouldn't occur when we are doing the penile prosthesis properly, and we're taking all the our considerations during the dilatation and managing in these cases, especially with cases of fibrosis. However, it may occur with even the excellent and the more expert, most expert surgeons. When some of the studies came for the only 4 studies asked for patient satisfaction in early and late penile prosthesis implantation, the satisfaction was much more higher in patients with early implantation than late implantation. Coming to the type of penile prosthesis, although most of us will use the malleable devices, and this was the case in this meta-analysis and systematic review, we found that the 214 malleable devices were implanted versus 104 inflatable devices. The malleable prosthesis will have many benefits in such cases. It's cost effective, it's easier to implant and easier to explant in case of infection, which sometimes expected in these cases. However, it has less concealment, leading to less satisfaction. When coming to the inflatable prosthesis, it's much more expensive. The operation itself is more demanding, needing more expertise. It's more difficult to explant in case of infection. You know, infection happens, we have to remove all the pieces of the prosthesis. We'll not remove only the inflatable part, but we remove the pump and the reservoir, which makes the operation more difficult. However, it has more concealment, leading to more satisfaction, and it has the added benefit of being antibiotic coated, decreasing the infection rate. So we can say from our meta-analysis that the early implantation has less total complications, less fibrosis, more satisfaction, versus more total complication, more fibrosis, and less satisfaction with the delayed implantation. However, we found that a lot of limitations that is present here we cannot give a solid answer whether to put early or late. The number of studies is little, with various designs, the various definitions for early versus delayed. There is no standardization for the even definition of complications. Some say fibrosis, the erosion, they talk about cross perforation during the operation. Some take erosion, that the erosion is post-operatively in the post-operative period. So even the definition of complications is different between one study and another. And some of the studies will have statistically insignificance due to data rarity. It's only reported by 1 or 2 of the studies and not all of them. So as a conclusion, it's more favorable to intervene within the early window of 30 days, or making early penile prosthesis implantation in such cases. However, should consider the severity of the priapism, the patient characteristics, preferences, and psychological aspects. If the patient is coming to us with a priapism, but he has uncontrolled diabetes, he has he has sickle cell disease, he is in a bad condition due to a malignancy. In these cases, we should consider, will we put the prosthesis or not? So we are not dealing with an organ, we are dealing with the patient. We have to have a holistic approach in such cases before deciding for an early or delayed. And a multidisciplinary approach is usually needed. I'm a urologist. I'll not have a decision in a hematologic patient like patient with sickle cell. Maybe the hematologist will tell me, if you opt for a prosthesis now, the patient will end with a penile gangrene. You should delay till we manage the patient well and he is controlled, then you will go for penile prosthesis. Similarly, we may have the aid of some psychologists. Some of these patients may come to you because they are having psychogenic element, and they are taking drugs or injecting themselves that cause the problem. So before, again, opting for going for the prosthesis, we should see if the patient will accept the idea of the penile prosthesis or not. So the counseling is very important before deciding for early or late. But the current evidence, we can see that early is more favorable. And I believe we need more studies and more multi-center studies to reach a more solid diagnosis. Thank you very much.
Thank you very much, Professor Arfa. It was a wonderful talk, and I think you have provided valid arguments in favor and against of both early and delayed. Indeed, penile prosthesis in early versus delayed are two very different surgical procedures. Delayed penile prosthesis placement is associated with a lot of complication rate. So that's one thing which really is in favor of early intervention. Before we conclude tonight's webinar, may I request Dr. Nasir Suleiman to say some words from his experience in managing these patients.
Thank you very much, Dr. Hamad. This was quite informative, I'm sure, for most of us. As mentioned by the speakers, we don't encounter this that frequently. But with the recent advent of the availability of PDE5 inhibitors, and when it fails, we do try to go for the intracavernosal injection, either therapeutic or as diagnostic. So it's quite important when we give these injections in order to prevent any ischemic episodes and of priapism. We should give it in graduated doses. We should not hurry it up. And especially also while the radiologist is doing the procedure, in order to prevent this complication, because most commonly in our part of the world, it is after the intracavernosal injection. Personally, in my practice, I've hardly seen any sickle cell disease. When I was in UK, we used to encounter this. So if one takes care of all these things, one is unlikely to encounter this rare complication. Dr. Wajahat figure of how to dilute it quite simply, which he has shown, will be quite helpful when the patient presents as an emergency. And as quite well informed by Dr. Ayman Yunus, he gave a very good presentation about the diagnosis and acute management. And we all know it's quite difficult to get the number of patients for a proper trial of delayed and early. But personally, I think early treatment would be better, because the severe fibrosis which one encounters would result in all the complications of dilating the corpus cavernosum and the resultant going here and there. So we still have to wait for the final verdict. And this was quite, all the speakers spoke quite well. They presented their case in the defined time, and this was quite informative. Thank you very much.
Thank you very much, Dr. Nasir Suleiman. One final word from Dr. Ayman Yunus.
Yeah, so absolutely right, Dr. Nasir. Not a lot of numbers, and we kind of learned from our seniors how to deal with things. One of the things that was actually repeated again by Dr. Wajahat and yourselves is that how to dilute phenylephrine and all that. This is something that it never stuck in my mind. So it's always in my, one of the files that I keep in my mobile, how to dilute this thing, because you don't have the time to look for it. Make it always available. And that's what I learned from my seniors as well. You will never memorize it. Keep it in your mobile or keep it anywhere else where it's actually available to you. And it happened to me last year. That's the last time I've managed a priapism. Maybe I had a bit of a panic to start with. Where can I find the dilution thing? And I found it in my mobile, and it worked just like that. So not a lot of numbers. You don't practice it too often. Hence, you don't memorize it that much. We keep like a stepwise approach, and things will go smoother after that. Most important thing I found in my last 2 or 3 cases of managing priapism is counseling the patient. There's a lot of litigations after that, a lot of litigation. So documentation, counseling, and weighing the risk of the benefits. I found that quite important in comparison to medical management as well. Thank you very much for that.
Thank you, Dr. Yunus. I think that's a very important point about litigation, because these are very sensitive patients. MR scans and biopsies are really important to at least document the level of fibrosis and ischemic injury for future. Dr. Wajahat, any further points, any specific comments?
Yes, just taking this point further, that is the real problem with early implant. Firstly, you have to convince yourself that this is a gone case. Then you have to convince the patient that it is now ischemic more than 48, 72 hours. And imagine the psychological and this litigation aspect in managing a simple case of priapism and adding the complications of penile implant on top of that. I would, and don't ignore the psychological aspect. I had one patient who was a doctor himself, used intracavernosal injections, presented with 10-day history of priapism, and after management and all, he came back to the clinic and he said, I used it again and it is not working. So imagine that situation.
Thank you, Wajahat. Professor Arfa?
Thank you very much. I don't know if I am fortunate or doomed, because I have seen a lot of priapism cases in Egypt, then in Saudi Arabia and Qatar because of the sickle cell anemia. It is endemic here. It is very, very common. I have to second my colleagues in saying that the counseling of the patient is very important. The patient comes in denial, and whatever decision you are taking, you must make sure that he properly understands the outcomes, he properly understands the expected complications, whether we'll go for any management, and especially with the penile prosthesis, this is an irreversible operation. Once the prosthesis, always a prosthesis. So the patient must be convinced, he must be counseled thoroughly about the early complications, the complication that may arise from his condition, that it's following priapism, and what is expected from the penile prosthesis and its longevity and everything. Thank you very much.
Thank you very much. And I'm really grateful to all the three speakers and the expert comments from Dr. Nasser Suleiman. I think we have a very comprehensive talk on priapism and its acute and long-term management. So with my gratitudes, I conclude today's webinar. Have a very good evening, and Assalamu alaikum and Khuda Hafiz.
Allah Hafiz.